I'm Dr. Uday Diwaskar. I'm Chief of Newborn Medicine, Neonatology at University of California in Los Angeles, UCLA, and I've been in neonatology for more than 40 years. My interest is in how to handle babies that are at lower level of viability, and also interested in some other research. In general, this would probably be true in the United States, but also true at UCLA, that babies that are born at less than 22 weeks of gestation, and generally they are less than 500 grams weight, are considered non-viable, in the sense that if they require positive pressure ventilation, we would not offer it. Now, there are some babies who have mature lungs and they can survive on their own without any need for ventilation. But if they do require mechanical ventilation, we feel very comfortable that we do not offer that. Babies that are more than 22 weeks gestation and probably weigh more than 500 gram, but less than 24 week gestation and less than 600 gram, I call it as a gray area. So we will respect parental wishes. Some parents want to do everything possible to keep the baby alive, and we'll do it. And some people do not want to deal with a baby who is mentally challenged, so we prefer or offer not to do any resuscitation. So that is generally our approach. Again, I'm talking about when the baby requires mechanical ventilation. Babies doing on their own is not an issue. We need to provide comfort. Now, for babies who are born even at less than 22 week gestation, and we think that they are not viable despite using mechanical ventilation and likely to have very bad outcome, we do offer them a very compassionate care, which may include keeping the baby warm, keeping the baby with the mother, occasionally giving oxygen, those kinds of things. But even then we talk to the family and tell them that it is very futile to do any one of those things, and most of the families are okay with that.
So what is the practice in your the hospital that you practice? What is the usual policy in such cases? How do you?
Yeah, so
I'm sure it differs a lot from India. So how do you usually go about such cases?
it differs to some extent from India, but I can tell you that if you have enough time available before the baby is born, which makes it much easier for obstetrician, the family, and for us. And in those situations, we would still tell them that when the baby is born and is crying and breathing on his own and all those kind of things, it's not an issue. We will do whatever needs to be done subsequently to take care of this baby. The issue comes is if the baby is not breathing well, or oxygenation is not good, the baby starts getting low heart rate and so on. Our approach is not to intubate or not to offer mechanical ventilation, not to which is compression. Respect baby's life and let the baby die in peace. There are very small percent of parents who will say, we want you to do everything possible despite my counseling. I said, okay, we'll do it, but the equipment is very small. The catheters and endotracheal tubes are very small, and it's very even difficult to put them on the ventilator. And despite using the ventilator, overall long-term mortality and morbidities are not very good. So majority of the parents will listen to me. But just because we started resuscitation in the delivery room does not mean we have to continue forever. If within 6 hours, 12 hours, 24 hours, 2 days, 3 days, if you feel the baby already has lack of oxygen and some damage done to the brain, we can discontinue support. And again, most parents are very okay with that.
So is there anything? Are there any specific criteria, like how do you decide that the baby needs to be resuscitated and now it's a time to stop, or let the baby go, give comfort care to the baby and parents?
Yeah, so based upon the gestational age, either mother's last menstrual period, early ultrasound, and maybe their basic physical examination shows that this baby is really very, very small and not viable, then we would not offer anything at all. So assessment is made that way by history, last menstrual period, ultrasound, and what we see when the baby is born.
The role of parental consent is very important as well.
Yeah, the role of parental consent is everywhere, whether it is verbal communication or whether it is a written consent and those kinds of things. I can tell you most of the parents are interested in doing that is good for the baby, and most of the doctors are interested in doing what is good for the baby. So majority of the time I do not have to document everything in a legal form, that I have a legal contract and this kinds of thing. But we do document what we are doing, what are the gist of our conversation with the parents, and that the parents are in agreement, in agreement with our plan. And like I said, majority of them listen to us. Occasionally, baby continues to be on the ventilator, but another day or two, they start recognizing that this baby is really very small and it's not worth continuing.